We did our project on an ACL tear. This is our patient. Her name's Tara. She's a 30-year-old female. She currently is a high school health teacher as well as the varsity soccer coach. Her hobbies include she loves to run every week about 10 miles. She's on a recreational soccer team that practices once a week and plays once a week. She loves playing with her 2-year-old son as well as assisting with Sunday school at her church. She came into the clinic complaining of right knee pain after her ACL surgery. She had surgery about 2 weeks ago. She injured it performing a zigzag drill. Pain, she's currently 6 out of 10, primarily where the incisions are, but she does have some general knee pain as well. It is sharp as well as achy, flexion, extension, alleviating factors. This sucks. Okay. So this is your ACL. I literally don't even know what to say. So the ACL is a ligament in the knee called the anterior cruciate ligament. This ligament connects your posterior medial corner of your lateral femoral condyle to the anterior medial intercondyle eminence of your tibia. The ACL is essential for normal knee function as well as stability, and the primary functions of it are preventing your tibia from sliding too far forward on your femur as well as hyperextension of your knee. We are going to do a surgical so she had a surgical intervention to fix it via a patellar graft tendon. Post-surgery, we're really concerned about her swelling and pain straight off the bat, as well as infection that could get into those incisions. Precautions: because of the patellar graft, we don't want to do any resisted knee extension for the first 4 weeks. Let's see. And then her long-term goal, this. Alright, so in the first phase of rehabilitation, we really firstly want to focus on her pain as well as the swelling stemming from her invasive surgery. Those are going to be our primary goals for her first 2 weeks. Then in the second half of phase 1, we're really going to focus on increasing to full knee extension, getting a lot of her AROM knee flexion back, as well as keeping her cardiovascular levels. For the ankle pump exercise, you're going to have your patient laying supine on the plinth. Their ankles are going to be slightly off the table. You're going to have them pull their ankle into a dorsiflex position and subsequently have them plantar flex. They're going to repeat this motion. For the isometric quad set, the patient is going to be in a long sit position. They're going to contract their quadriceps, creating a visible superior movement of their patella. This contraction should be held for about 5 to 8 seconds, followed by a gradual decline into full relaxation. For your upper extremity cycling, you're going to start with your shoulders in neutral and your elbows flexed to 90 degrees. You're going to slightly flex and extend your shoulders as well as your elbows in order to make a cycling motion. And then talk about these videos a little bit afterwards. So for her second phase, that's primarily going to be around weeks 4 to 8. At this point, she's going to be just coming out of her brace, provided she doesn't have any pain with walking. She might have a slight antalgic gait, but as long as it's minor, we can work on it. Primarily in this stage of her rehabilitation, we really want range of motion back. By the end of it, we want her in complete knee flexion range of motion, as well as starting sort of her more proprioceptive, as well as that kind of stuff. For the straight leg raise, the patient will lie supine with their uninvolved knee flexed and their involved knee fully extended. Their hip should be in neutral. The patient will isometrically contract their quads and keep their knees straight. The patient should slowly lift their leg till it's about 12 inches off the table, ensuring that the maintenance of full knee extension remains in place. The athlete should pause momentarily at the top of motion before slowly returning the limb to its starting position. To perform the double leg balance with a foam pad and visual feedback, the patient should stand shoulder width apart on an Therex pad. The patient can then perform a squat while looking in the mirror for visual cues for self-correction. For the standing quadricep stretch, the patient should stand with their glutes to the table. Their knees should be flexed and the dorsal part of their foot resting on the surface of the table. The patient should try to pull their foot into their buttocks. So moving into phase 3, now we're looking at about 2 to 6 months for this phase. This is where we're gonna be really focusing and honing in on our strength. First off, our quadricep strength, super important to get that patellar grafts like super strong. Glute strength, because we want to be able to move everything, as well as hamstring strength. Those are going to be sort of our top ones straight off the bat. At the end, we're going to start some low-level plyometrics to make sure she has enough strength and power to start jumping. That's sort of important in soccer. As well as some easy functional, and of course keeping that cardiovascular level up. You don't want to get behind on that. And then strengthening her core, which we're going to do through a lot of exercises. For the single leg bridge, the patient is going to lie supine with their top knee bent to 90 degrees. The patient will push their heel into the table and lift their hips until they are level with their knees and trunk.
For soccer ball toe touches, the patient is going to start off standing with a soccer ball out in front of them. Then they're going to place the toes of one foot on top of the soccer ball. Then in a quick pace, they're going to alternate the toes that are on top of the soccer ball. For the double leg forward hop, the patient is going to start standing with the feet shoulder width apart. Then they're going to quickly, concentrically contract into a partial squat before they explosively jump and hit the next pad.
Phase 4, we're going to hit it real aggressive. We really want to increase our plyometrics more to the medium, even increasing up to the maximal level. We're going to work on some harder functional stuff to make sure that when she gets back into her job, gets back into her hobbies and all that kind of stuff, she's going to be able to perform and do these type of things. And then at the end, we're going to move into sports specific. This is her soccer stuff, as well as her job. Being a teacher, she needs to raise up a lot. Playing soccer, she obviously has to have a lot of lower body agility as well as strength and sort of movement in that.
For tuck jumps, the patient is going to start with their feet shoulder width apart. Then they're going to perform a quick concentric contraction into a partial squat, and then explosively jump up, bring their knees up to their chest. For juggling, the patient is going to use their head, chest, thighs, and feet to keep the ball from touching the floor.
Okay, so our patient underwent an operative treatment, but there is a non-operative treatment that can also be done. This is going to be for people who have partial tears and are willing to give up sort of more impact sports and live a sedentary lifestyle. It's really not very effective at the end. Most people do require surgery later on because you're living your life basically without your ACL. Operative is much more effective. You're looking at usually a 9 to 12 month recovery time, as well as some scarring. There are 2 types of operative. You can have sort of a more accelerated, in which these are for high level athletes, practice every day, super in shape and super motivated, and they can usually come back in about 6 months. Whereas the normal population, this is going to be about 90%, 95% of us are going to be the conservative treatment, which is 9 months at the earliest to about 12 months. Here is our works cited page. End of show. Okay, I'm done.